All right, guys, let's go ahead and get started. Can everybody hear me?
I can hear you.
Okay, awesome. Okay, so I just sent a picture through Remind, and I want everyone to take a quick look at it, okay? Now, again, I know that a lot of this, um, well, Alicia put it in good terms. It looks like a lot of jumble, okay? And that's okay. I expect it to kind of look that way. This is something that really, it's just about studying and trying to break it down to understand how to not necessarily read an EKG, but recognize the parts of an EKG. Natalie, you may have to try to get back on and get back in if you're having a hard time hearing me. Okay, so the picture I sent you guys, I want you to kind of take a look at it real quick, okay? And I really want you to label your EKGs or even draw up a trace of that, okay? And try to kind of break it down to where you can understand it. So you have a PR interval. It extends from the beginning of the P wave until the beginning of the QRS complex, which is onset of atrial depolarization to the onset of ventricle depolarization. Okay, so I want you to look at it. We have AD, AR, VD, VD, VR. What do we think AD means? Anybody? What do we think AD would mean?
I have no idea.
Okay, all right. So that's going to mean atrial depolarization. AR would mean what? If AD is atrial depolarization, then what would AR be?
Atrial repolarization?
Yes, yes. All right. So what would we think VD means?
Uh, Ventricle
Yep,
depolarization?
that's right. So your ventricle depolarization, you'll see that it's in between the QRS complex. And then right below that is another VD, which is ventricle depolarization. And then we have VR. What would that mean?
Repolarization.
That's right. So when you're looking at this on your certification, you basically take, if you could imagine a line drawn right in the middle, okay? And our alphabet goes from A to Z. Well, remember A is the first part of the alphabet. So that's going to go in front. D comes before R. So atrial depolarization and then atrial repolarization. And on the other side of that high spike, you have V, that's the close to the end of the alphabet. And then we have D and then VR. So that's how I want you to study this. So in front of the high spike, you have A. And then D becomes before R. After the spike, V. And then again, D comes before R. Does that kind of make sense?
Yes.
Okay. So that's how, when you look at this, that's a good way I want you to take this sheet and be able to study it. So you can imagine that. So when it comes in time for certification, you're like, oh, I know that that is atrial depolarization. I know that this has got to be, if that's atrial depolarization, then this has to be ventricle depolarization. Okay? All right. So again, the CCMA EKG study guide, EKG and ECG is the same thing. You may hear it called one or the other. But this little first sheet is basically breaking it all down specifically into what it is. So a PR segment, it's line from the end of the P wave to the onset of the QRS complex. Then it goes into your P wave, your T wave, the ST segment. It just breaks it down so you understand what each little thing means. And then it's giving you a visual. So it says sheet 1. Okay, we'll go to sheet 1 and it's going to tell you, okay, here's the PR segment is right there. It looks like that falls after my P and before my R. So it just breaks it down individually. And then I'm giving you the sheet so you have an image to go by. So you can break this down however you need to be able to study it. Okay? That's all that this is. It is study material. Okay, any questions about anything right now? Hey guys, hold on just a second. All right, so any questions about anything right now before we start back on the book? Okay, everybody turn your page to 475. Alicia, go ahead and start reading event marker, please.
Event marker?
Yes.
Okay. Some Holter monitor models have an event marker button which is used along with the patient diary for patient evaluation. When the event marker button is pressed, a beep may sound as an audible feedback. The patient should be told to depress the button momentarily when experiencing a symptom and then document the time and nature of the symptom in the Holter diary. Depressing the button places an electronic signal on the recordings. The signal highlights the specific portion of the recording where the symptom occurred. When a computer analyzes the patient's data, the time of the event along with the ECG event strip will be included in the ECG report.
Very good, thank you. Okay, so we stopped by starting to cover the Holter monitor. So again, the Holter monitor is something that a medical assistant may place on the patient. The patient would be sent home with this Holter monitor for maybe 24 hours. And then while it's in the patient's care, these are things that the patient would do that's going to help the technicians and the doctors read the report, okay? So an event marker is something that a patient would do, be like, okay, I'm starting to feel, I think that feels like heart palpitation. So I'm going to hit the event marker. And then I'm going to take my patient diary and I'm going to record today's date and the time it is right now. Feel like I'm having heart palpitations, or feel like I might pass out. Okay, so they're going to tie it in with the diary and the event marker. They're going to tie the two and they're going to look at the reading to see if there really was anything going on during that time that could be triggering to why the patient's having symptoms. Okay? All right, evaluating results. At the end of the monitoring period, the Holter monitor system is removed from the patient. The information on the memory card is then uploaded to a computer. Specialized EKG software performs calculations on the data and prepares it an EKG summary report on the monitoring period, which is then displayed on the screen of the computer. The computer-generated EKG report summarizes information about the patient's heart and rhythm and any abnormalities that occurred during the monitoring period. The report also includes selected samples of the patient's cardiac activity, including patient event strips and any abnormal cardiac activity exhibited by the patient, such as dysrhythmias. The results of the EKG summary report are reviewed and interpreted further by the provider. The provider also reviews the patient's diary to determine if there is a correlation between any of the patient's activities, emotional states, or symptoms and EKG abnormalities. The EKG report can be printed out on regular sheets of paper using an inkjet or laser printer and stored in a PPR, paper-based patient record. It can also be stored electronically in the patient's EMR, electronic medical record. All right. Lily, please read maintenance of the Holter monitor.
At the end of the period, the batteries should be removed from the monitor and discarded. Leaving a battery in the monitor could corrode the battery, which could damage the monitor. The casing of the monitor should be cleaned frequently using a soft cloth moistened with a mild disinfectant to remove dust and dirt. Commercial solvents and abrasives should not be used because they can damage the finish of the casing. The patient cable and lead wire should be cleaned periodically with a cloth moistened with a mild disinfectant. The cable and lead wires should never be immersed in the cleaning solution because this could damage them. The snap of each lead wire should be cleaned with alcohol and a small brush to eliminate any trace of the gel remaining after the use of disposable electrodes. The monitor should be stored in a dry, dust-free area.
Very good. Thank you, Lily. Okay, so just like with our EKG machine and any other machines that we've used in the previous chapter, it's our job to make sure that they function properly and we clean them properly. Same thing goes for the Holter monitor, okay? Okay, so let's take a look at the figure 12.17. So this is a Holter monitor diary. This is really what it looks like. Like you get this little sheets, or even sometimes they make these little small books in your cardiologist area. And that's what a patient diary. So you'll make sure that the patient has a diary and understands the use of a Holter monitor. All right, procedure 12.2 is applying the Holter monitor. The one thing I want you guys to take a look at on page 477 is 8A picture. What is that medical assistant doing?
The hair?
Yes.
Probably so the stickies will stick better.
Thank you. Yes. Now, because the Holter monitor uses electrodes, just like our EKG machine or our ECG machine, again, it's the same thing. You may also have to do this on your male patients for an EKG, just like the Holter monitor. If our patients are extra hairy, yeah, we're going to do a little patch shave, and that is something you will do. Because again, we want to make sure that our electrodes are getting great connection to the skin. So that's one less what that will not occur.
Wrong. Like it'll record it right, it won't miss anything, or
No, it will. Yeah. So if the electrodes don't get a good skin connection,
Yeah.
it can cause artifacts. It can cause a mislead in the EKG readings. Like it just shows it didn't get a good connection. So all right. Yeah. So again, we have to make sure that we are making sure we get good contact. Okay, so now let's go on over to page 480. And Natalie, go ahead and read the first paragraph for cardiac dysrhythmias.
Normal ECG graph cycle consists of a wave A4S complex which repeats regular pattern C12.5. Normal sinus rhythm refers to the ECG that the wave segments and cardiac rate fall within the heart rate ranges from 60 to 100 per minute. A rate slower than 60 is sinus bradycardia, and a rate faster than 100 is tachycardia.
Okay. So I want you guys to highlight the second sentence where it says the term normal sinus rhythm refers to an ECG that is within normal limits. All right, Sabrina, go ahead and read that second paragraph, please.
Cardiac dysrhythmia is a term used to describe abnormal electrical activity in the heart causing an irregular heartbeat. Cardiac dysrhythmias can be classified into one of the following categories: extra beats, an abnormal rhythm, or an abnormal heart rate. Most cardiac dysrhythmias are harmless, however, some can be serious or even life-threatening. The medical assistant should be able to recognize basic cardiac dysrhythmias on the electrocardiographic recording for the purpose of alerting the provider of their presence. The dysrhythmias, the the medical assistant should be able to identify are presented next, along with the brief descriptions and significant clinical aspects.
Very good, thank you. Okay, so you're going to highlight the first sentence, and then I want you to highlight the words 1 extra beats, 2 an abnormal rhythm, or 3 an abnormal heartbeat. All right. Talia, can you please read premature atrial contraction for the description?
Premature atrial contraction (PAC) is characterized by a beat that comes before the next normal beat is due. The most distinguishing feature is that the P wave of the premature beat has a different shape from the P wave of the normal beat. The premature atrial contraction has a normal QRS complex and a normal T wave similar to the other ECG graphic cycle.
Very good. Okay, you're going to highlight the first sentence. All right, Alicia, go ahead and read clinical significance, please.
Okay. Wait, which one?
Clinical.
The under the premature atrial contraction?
Yes, ma'am.
Okay. Premature atrial contractions are common in healthy individuals and are often associated with the intake of stimulants such as caffeine and tobacco. They also can be associated with more serious atrial dysrhythmias and structural heart disease.
All right, very good, thank you. Okay, so I want you to highlight the words intake of stimulants such as caffeine and tobacco. Okay, so I want you ladies to look where it says premature atrial contraction. This little graph right on the middle of page 480. I want you to look at those lines and tell me if you see something different. Do you see something different?
On the premature atrial contraction?
Yes.
It's not, it doesn't look like there's like a resting pulse. Do you know what I'm saying?
Yeah.
Like usually it's the line and then the little boom boom and then the line and then it goes up again, but this one it's like constant wavy. Like constant waves.
Well, yes, it is. The one thing I want you to look is I want you guys to start at the very first, and it goes a little small hump and then a high spike. Down, another small hump, and then it slowly goes into the same next thing. And it keeps going. But then all of a sudden, right before you get to the middle, where the width from the spikes are like this, all of a sudden it's like this. That is a premature atrial contraction.
The one where it's literally just like chilling. It's just a line. Or which one?
Okay, so it go 1, 2, 3, 4, and in between the fourth and fifth spike.
Uh-huh.
All right, do you see how the width between the two spikes are not as wide as the other
Oh,
ones?
yes.
Okay, so right after that fifth spike, right in between that, that is a premature atrial contraction. Right? Like it's like it's a beat popped in quicker than what it has been, right? It just it goes do 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 do. So it's space, equal, everything looks normal, and then all of a sudden it doesn't.
Yeah. Nancy, we're on page 480.
Yes, Nancy, we are. Thank you for finally getting. I'm sorry you had trouble getting on. Okay, so that's what a premature atrial contraction looks like. So
Okay.
now we're going to go over paroxysmal supraventricular tachycardia. What is tachycardia again, ladies?
Heartbeat.
Yes, fast heartbeat. Okay, so let's see here. Jasmine, are you where you can read the description?
Is it following after what it says? Like where it says the word?
Yes, PSVT. Yes.
Okay. Is one of the most common rhythm disorders often occurring in healthily patients with underlying. Is that right there?
No,
Or
go
hold
over
on.
to your left under description, not clinical
Oh, okay.
symptoms. Yeah, there you go.
Um. Okay, where is that? I'm sorry.
No, you're okay. So it's pronounced paroxysmal
Mhm.
supraventricular tachycardia.
Okay, where it has in like parentheses too, the
Yes.
PSVT. Okay. It's an abrupt episode of tachycardia with a constant heart rate that usually falls between 150 and 250 beats per minute. PSVT is characterized by a rhythm that has a sudden onset and termination. The sudden increase in rate occurs in short bursts and lasts only a few seconds, after which the rate returns to what it was before the paroxysmal
Uh-huh.
supraventricular tachycardia occurred. Because of the increase in heart rate, the ECG graph cycles are very close together. With PSVT, the patient experiences a sudden pounding or fluttering of the chest associated with weakness breathlessness, and acute apprehension. Occasionally, the patient experiences how do you say that? Syncope
Uh-huh.
of their presence. The dysrhythmias. The medical assistant should be able to identify are present next, along with brief descriptions of significant clinical aspects.
Oh, okay. All right. So what is syncope? We spoke about it earlier this morning. Anybody? What is syncope? Okay, so another meaning for syncope is fainting. Clinical significance. Paroxysmal supraventricular tachycardia is one of the most common rhythm disorders, often occurring in healthy patients with no underlying heart disease and young adults with normal hearts. It can also occur in individuals with organic heart disease. Atrial flutter. Atrial flutter is a rapid, regular fluttering of the atrium, in which the heart rate falls between 250 and 350 beats per minute. More than one P wave precedes each QRS complex, and the P wave appear as saw-tooth spikes between the QRS complexes. The number of waves can range from just one extra P wave to 8 falling in rapid succession, but all have the same size and shape. The QRS complexes of an atrial flutter configuration are normal. However, the T wave is usually lost in the P wave. All right, so really quickly on page 480, under the PSVT, I want you ladies to highlight the first two sentences and highlight what the patient experiences. And on page 481, that is an example of your PSVT. All right, now we're continuing on page 482. Clinical significance. Atrial flutter rarely occurs in healthy individuals. It is found in patients with underlying heart disease. Highlight that sentence. Atrial flutter is not specific to any particular heart disease. It can occur in patients with mitral valve disease, coronary artery disease, acute myocardial infarction, chronic lung disease, hypertensive heart disease, and pulmonary Ebola, and in patients who have undergone cardiac surgery. All right, and then here is an example of what atrial flutter looks like on an EKG. So what is the difference between this picture and the graph on page 480?
They're closer
Instead of
together.
One more time.
I don't know who was trying to talk.
Okay, go ahead.
We started two at the same time, so I don't know who's talking first.
It's all right. Tell me the difference.
So on the other one, it's like pointing upward, and this one's going down.
on the top graph on page 482?
Yes.
Okay. Okay. So it's almost like it's not really, I mean, it's a pattern, but it's not, right? Like it's just kind of like the spikes are going up and it's this. All right. In a normal EKG, it's going to be a really nice, clean cycle, right? It's going to go up, like you can actually tell right where each little thing is. You can tell where the QRS wave, you can tell where the P wave is, right? And on these, they're so close together, it's really hard to tell. Okay, so that's atrial flutter. So the next condition is atrial fibrillation. All right, so let's read the description about that. Nancy, go ahead and read the description for atrial fibrillation.
Atrial fibrillation is characterized by an ECG in which the P waves have no definite pattern or shape. The P waves appear as irregular wavy undulations between the QRS complexes. The QRS complexes is arterial fibrillation are difficult to measure accurately, and arterial waves are discernible. However, the arteria are contracting between 400 and 600 times per minute. The ventricular rate may be rapid, 150 to 180 beats per minute, and relatively normal.
Very good. All right, so before we go into the clinical significance of the atrial fibrillation, let's look at the graph paper. So this is an example of what it looks like when a patient is in AFib, right? That's another name for atrial fibrillation. It's AFib. So what's the difference between atrial flutter and atrial fibrillation?
Atrial fibrillation.
Their beats are different. The fibrillation has 400 to 600, and the flutter has 250 to 350.
Okay, but what does the difference look like on the paper?
Pattern?
Natalie, try turning up your volume on your device.
I have a question.
Yes.
So you're asking us like what the difference is and stuff, and obviously there's a clear difference, but how do we explain that to you? Because like I don't
Arterial
really
fibrillation.
What?
Arterial fibrillation.
what?
Okay, so Alicia, to answer your question, just in your best words. I mean, I don't expect you to be medically terminology on describing it. Just in your own words, what describe the differences you see. Like for me, I'd be like, well, for starters, the high spike looks like it's completely flipped to the underside, right? It's instead of going up, it's going down.
Yeah.
Yeah. So just in your own words. I don't expect
Miss
you guys
Daniels,
to. Yeah. Yes, Nancy.
I'm sorry. I'm a little behind here because I started late, so I'm a little confused. But as far as what I can see, the difference is, from there is really not. It's a pattern, but not really a pattern, because what happens is, those lines that go up, it's they're upwards instead of downwards, compared to the fibrillation part. And then, I don't know what you call the middle part, but they're little zigzag thingies. They're like, they're small, but they're more, as compared to the bottom ones. They're a little larger, like a little bigger. Um, and I guess that's the fibrillation. There's more of a pattern that I see.
Yes, in a way. So the one thing, so the reason that it looks so, what's a good word I can say? Where it looks so busy, right? That's where the tachycardia comes in. So just like with atrial flutter and atrial fibrillation, you can see the tachycardia. Now, not in all patients, because like I said, it could also be a normal heartbeat. But if you're running an EKG, what I'm trying to do is I'm trying to get you guys to see to when you're running an EKG, some of these things you can pick up on, right? Even if you're not 100% sure what each little thing is, you should be able to see a pattern, right? A normal pattern. And then now you're looking at what's a not normal pattern, right? So you can start picking up on some things just by looking at it. Like with atrial fibrillation, it to me sometimes can be in some patients easy to look at on a piece of paper because it looks just like that. Well, if all you're running is on normal patients, right, you're going to have a nice, beautiful pattern reading. And then all of a sudden, you do a reading on a patient that's got AFib, and you're like, whoa, what is going on here? You can pick it up. You can start looking and actually seeing some abnormalities in the EKG just by looking at it. Okay. It's just trying to kind of get you in the idea of knowing what some of the abnormal readings, what they look like. So you can be on the lookout for them because again, you're not diagnosing the patient, but it's a good learning tool. And if you're going to be working with
So,
a
Miss,
cardiologist, they're probably going to really, really teach you this more in depth. So it's pretty cool to kind of learn it and see it. All right. Any questions before we do the clinical significance for AFib?
out of the arterial flutter and the arterial fibrillation, what actually looks like a normal?
Well, neither one of those look normal. All right. So if you will go to, let me see if I've got a good. All right. Turn to page 466 on figure 12.12. That's what a normal can look like. Okay. And you compare it with AFib and atrial flutter. So you see on 466, it's a nice pretty, like I see the spikes, I see the spaces. That's beautiful, right? And then you go to page 42 and you're like, whoa, what is going on here? That doesn't look normal. So can you see kind of the difference now?
It's pretty. But I also see that, for example, on the first line, I see that the spikes go up, and then on the second one, it goes down. Then on third one is down, then the fourth one goes up.
Hmm? Yep.
And then on the next line, I see the spikes go up, and then down, then up. So wouldn't that be, that to me, because I don't know how to read it, I'd look at that as not normal.
That's right. That's right. So the reason why this is normal is because, again, well, and when you watch the first recording, okay, you're going to see that the way an AVR reads, the way V1 is reading, the way AVL is reading. So you're going to be able to look at it. And then once you understand how to read this, then you're going to be able to see it. Okay, that's why I sent this. And again, it's not that you guys are going to have to know how to read an actual EKG, but you do need to be able to identify the parts of an EKG, right? Like, what is a QRS complex? What is a P wave? And that's what those sheets are going to help you on. This chapter is a little different, but and then once we do the EKG in the clinic, you're also going to be able to see it. You can kind of get a little more understanding as far as knowing it and doing it all together. All right, any other questions?
I don't think so.
Sabrina, go ahead and read clinical significance for me for atrial fibrillation. Okay. Talia, can you go ahead and read clinical significance?
Atrial fibrillation is a common dysrhythmia that can occur in healthy individuals and in patients with a variety of cardiac diseases. In the healthy individual, it can be irritated by emotional stress, excessive alcohol consumption, and vomiting in the individuals younger than 50 years old. The common causes of atrial fibrillation are congenital heart diseases and rheumatic heart diseases with mitral valve involvement. In individuals, in individuals older than 50, arterial fibrillation is caused by diseases capable of producing either
Ischemia.
what's that?
Ischemia.
Ischemia or hypertrophy of the arteria, such as coronary artery diseases, mitral valve diseases, and hypertensive heart diseases.
Okay, good. All right, I want you guys to highlight where it says atrial fibrillation is a common dysrhythmia. All right, so our next one is premature ventricular contraction, also known as PVCs. So premature ventricular contractions, PVCs, are among the most common rhythm disturbances seen on an ECG. Highlight that sentence. The PVC is characterized by a beat that comes early in the cycle, is not preceded by a P wave, has a wide and distorted QRS complex, highlight that, and has a T wave opposite in direction to the R wave of the QRS complex. Because of the unusual configuration of the QRS complex, the premature ventricular contraction easily stands out from the normal EKG graph cycles. The baseline distance after the PVC is usually longer than normal distance between the other cycles. In other words, the premature ventricular contraction is followed by a pause before the next normal beat. Clinical significance. premature ventricular contractions are seen in normal individuals in all ages and are caused by anxiety, smoking, caffeine, alcohol, and certain medications. For example, is epinephrine, isoproterenol, aminophylline. Highlight that sentence. PVCs can occur with virtually any type of heart disease, but are seen most often in patients with hypertensive heart disease, ischemic heart disease, lung disease with hypoxia, and digitalis toxicity. PVCs also are common in individuals with mitral valve prolapse. Highlight that sentence. And then there is an example of what a PVC would look like on your EKG paper. Next is ventricular tachycardia. Ventricular tachycardia consists of a series of 3 or more consecutive premature ventricular contractions that occur at a rate of 150 to 300 beats, 300 per minute. Highlight that. The tachycardia may occur proximally and last only a short time, or it may persist for a long time. The QRS complexes are bizarre and widened, and no P waves are present. Sustained ventricular tachycardia is life-threatening dysrhythmia because the rapid ventricular weight prevents adequate filling time for the heart, leading to reduced cardiac output that often degenerates into ventricular fibrillation and cardiac arrest. Make sure you highlight that first sentence. Clinical significance. Ventricular tachycardia is usually seen in patients with acute or chronic heart disease. Runs of ventricular tachycardia indicate coronary artery disease. Ventricular tachycardia also occurs in complication of myocardial infarction. All right, so here's an example of what it would look like on your EKG graph paper. Any questions so far? All right, Alicia, please read the description for ventricular fibrillation.
Ventricular fibrillation, VFib, is the most serious dysrhythmia. With this type of dysrhythmia, the ventricles do not beat in a coordinated manner, but instead they quiver or fibrillate. Because of this, virtually no blood is ejected into the systemic circulation. On an ECG, ventricular fibrillation is characterized by irregular, chaotic, and undulations of the baseline. There are no recognizable P waves, QRS complexes, or T waves in the irregular line of jagged spikes. Because the ventricles are quivering irregularly, there is no effective ventricular pumping action, resulting in no circulation. Ventricular fibrillation is a serious dysrhythmia that must be treated immediately because it can lead to death.
Very good. I told you guys from now on we're going to be getting some doozy on some words. Okay, so highlight the first sentence, and where it says, because of this, virtually no blood is ejected into the systemic circulation. All right, Jasmine, will you please read clinical significance on page 484?
The most common cause of ventricular fibrillation is an acute myocardial function. It also can occur in patients with organic heart disease and cardiac dysrhythmia. It may be preceded by dysrhythmias such as premature ventricular contractions or ventricular tachycardia, or it may occur spontaneously.
Very good, thank you. Okay, highlight the words acute myocardial infarction. Okay, so what is the name of this chapter?
Cardiopulmonary procedures.
Very good. All right. And if I say cardio, what does that mean?
Heart,
Yes. If I say pulmonary, what does that mean?
lungs.
Yes. All right. So we just covered the heart side. Now we're going to start covering the lung side. Okay. So starting off, we have our pulmonary function test. The purpose of a pulmonary function test, PFT, is to assess lung functioning, assisting in the detection and evaluation of pulmonary disease. Pulmonary function test includes spirometry, lung volumes, diffusion, capacity, arterial blood gas studies, pulse oximetry, and cardiopulmonary exercise test. Highlights all that I just stated. The most frequently performed pulmonary function test is spirometry, which is described in detail in the next section. Procedure 12.3 outlines how to use a spirometer. All right. Lily, please read the first paragraph for spirometry.
Spirometry is a simple, non-invasive screening test that is often performed in the medical office. A computerized electronic instrument known as a spirometer is used to conduct the test. A spirometer measures how much air is pushed out of the lungs and how fast it is pushed out. The spirometry report is printed out as a table and graph. Spirometry is considered a screening test, and abnormal test results may require that the patient undergo additional pulmonary function tests and possibly computed tomography scan before a diagnosis can be made. Indications for performing spirometry include the following.
Okay, stop right there for me. All right, computed tomography scan. What do we think what is that also called? Does anybody have a guess?
That little thing that you blow into?
No. Computed tomography scan.
Is it like a CAT scan or?
Yes, what's another name for CAT scan?
An MRI?
Nope. It is another scan though. I'm looking for a specific common.
CT scan.
Yes. So a computed tomography scan is your CT scan. Okay. Okay, so I want you guys to highlight where it says that spirometer is used to conduct the test. A spirometer measures how much air is pushed out of the lungs and how fast it is pushed out. All right. Lily, you can go ahead and read 1, 2, 3, 4, and 5, please.
Patients who exhibit symptoms of lung dysfunction, such as dyspnea, individuals at risk for lung disease because of smoking or exposure to environmental pollutants, such as coal dust, asbestos, and oxidized fumes. Patients with lung disease, such as asthma, chronic bronchitis, and
Emphysema.
Patients who are to undergo surgery to assess probable lung performance during an operation, and patients who need to be evaluated for lung disability or impairments for a compensation program.
Very good. Okay, so you're going to highlight 1, 2, 3, and 4. Okay, so the spirometry test results. The results obtained from spirometry testing provide numerous measurements that help the provider assess lung functioning. The most important parameters are described next. Forced vital capacity. Forced vital capacity, FVC, is the maximum volume of air measured in liters that can be expired when the patient exhales as forcibly and rapidly as possible and for as long as possible. Highlight that sentence. Forced vital capacity is obtained by having the patient perform a breathing maneuver. The patient is instructed to take a deep breath until the lungs are completely full. Following this, the patient is told to blow out the air of the lungs in and into the mouthpiece as hard and as fast as possible until no more air can be expelled. To be considered an adequate test, the patient must forcibly blow out all the air from the lungs and continue smooth, continuous exhaling for at least 6 seconds. To be considered a valid test, a minimum of 3 acceptable efforts must be obtained. Some patients have difficulty performing the FVC breathing maneuver because they have a physical impairment or poor motivation, or they do not understand the instructions. The medical assistant should be patient and work with these individuals to help them perform the maneuver. If patients are unable to perform the maneuver after 8 attempts, however, testing should be discontinued. At this point, fatigue may affect the accuracy of the results, and additional efforts are not recommended. Okay, so now we're at case study number 2. Joel Matthews, 48 years old, is at the office for a biannual checkup. Joel had a mild heart attack 2 years ago. Since then, he has completely changed his life. He's become a vegetarian and practices yoga every morning before going to work. After he gets home, he jogs 10 miles. Good Lord. He also lifts weights every other day and takes herbal vitamin supplements. Since his heart attack, he has lost 40 pounds and says that he has never felt better. The only thing he cannot seem to do is give up smoking. He started smoking when he was 17 years old and has cut back from 2 packs to 1 pack a day. He keeps trying to stop, but says that he has been smoking so long that it might not be possible. Besides, with all the other healthy stuff he is doing, he thinks it probably cancels out the bad effects of the cigarettes. Joel is very concerned that if he does not stop smoking, he'll gain back all of the weight that it took him so long to use. Okay, so medical assistance, what's the first part? What would you do?
Since he's here for a checkup, I think we need to make sure that we've documented that he went from 2 packs a day to 1 pack a day, and also the vitamins that he takes.
Yes, very good. Good. All right, what else do we need to do?
Weight.
Yep. All right, what else?
We could give him resources and information about ways that you can quit smoking without quitting cold turkey, just because there's a lot of things that you can do if you can't quit on your own.
That's right. That's right. And then at that point, you can go ahead and let the provider know, hey, I think he's really wanting some more information on how he can quit smoking. Okay, is there anything else that we want to do?
Maybe have the provider let him know that just because he started doing a lot of healthy stuff, that doesn't cancel out him smoking cigarettes, because he could develop, I don't know, COPD or something like that can make him susceptible to getting sick very fast, obviously, since he's had a heart attack already.
Yeah, that's right. Okay, anything else? Okay, what about, let's flip it around. What do we not want to do?
Make him feel bad about smoking.
That's right. That's right. We don't want him to feel bad. So the fact that he has made really great strides, right? I mean, like he's really, really taken this heart attack very seriously. Sometimes it's easy for us to change a lifestyle when it affects our heart, but you're going to find that for patients that smoke, it is honestly, for some patients, it is really hard, like super, super hard. So the fact that he's even talking about it, that's really good, right? Like that's pretty good. We need to make sure we don't make him feel bad. What else do we not want to do? Are there any other ideas for what to do?
He had a heart attack 2 years ago. Should we do an ECG on him?
Um, that is a good question. In most cases, probably yes. But at the same time, your provider probably will say, let's go ahead and do an EKG. Because
Okay.
if he's had a heart attack, so he probably is already seeing his specialist, his cardiologist, and I bet that that's something that they do. What
Okay.
you could make sure that if you ask him, do you see a cardiologist? And he's like, oh yeah, I do. Okay, what's the name of your cardiologist? Because then we can get records.
Okay.
So that is a good point. All right, very good. Anything else? No? Okay. Well, very good. So you guys did good. All right. So next is going to come forced expiratory volume after 1 second. VFV, sorry, FEV1. This is a tongue twister for me. All right. Forced expiratory volume after 1 second, FEV1, is the volume of air in liters that is forcefully exhaled during the first second of the FVC breathing maneuver. Spirometry automatically determines this parameter from the FVC maneuver. All right, FEV1 to FVC ratio. Nancy, please read the first paragraph.
In patients with healthy 70% to 75% of the air exhaled, FVC is exhaled in the second FEV1 of the breathing maneuver. This comparison is known as the FEV1 FVC ratio, and it is expressed as a percentage. A patient with healthy lungs may have a FEV1 FVC ratio of 85%. This means that 85% of the exhaled air was exhaled during the first second of the breathing maneuver.
Very good, thank you. All right, Natalie, can you go ahead and read the next paragraph, please?
In patients with chronic obstructive pulmonary disease, the FEV1 FVC ratio is less than 70% to 75%. These patients are unable to move most of their exhaled air out of the lungs during the first second because of an obstruction to the airflow, such as inflammation or damaged lung tissue. Based on the FEV1 FVC ratio, the obstruction is characterized as mild 61% to 69%, moderate 45% to 60%, or severe less than 45%. Figure 12.18 shows a graph of spirometry parameters in a patient with healthy lungs and in a patient with obstructive pulmonary disease.
Very good. I don't know about y'all, but when I have to say FEV1 and FVC, I kind of get a little twisted. I don't know why. All right. Evaluation of results. Sabrina, are you where you can read the first paragraph?
Yes. To evaluate the spirometry test results fully, certain demographic factors must be taken into consideration, including the patient's age, sex, weight, and height. This, these these demographic factors are used to calculate the predicted values, which is what the results should be for a patient with healthy lungs. When the test is when the test is run, the provider compares the patient's measured values with the predicted values. For example, the FVC predicted value is 6 liters and the FVC measured value is 4 liters. This means that the patient should have been able to exhale 6 liters of air based on age, sex, weight, and height, but he or she was able to exhale only 4 liters of air.
Very good. Okay, so you guys are going to highlight where it says calculate the predicted values, which is what the results should be for a patient with healthy lungs. All right, Talia, go ahead and read the next paragraph, please.
Did you say me?
No, I said Talia.
Okay, I didn't hear. Sorry.
Is it in the patients with the chronic
No, under evaluation of results where it says a computerized spirometer.
Okay. The computerized spirometer automatically calculates the predicted values use demographic information entering into the machine by the medical assistant. The pre-medical value and measure the values are printed on the spirometer report. Figure 12.19 show an example of these results. Compare the measured values of the predicted values, assisting the provider in detecting the presence of the pulmonary disease.
Very good, thank you. Okay, Alicia, can you go ahead and read patient preparation?
Patient preparation is essential to obtain accurate test results. To prepare, I'm sorry. Oh my goodness. Okay, to prepare for the test, the patient should be instructed to do the following. Number one, do not eat a heavy meal for 8 hours before the test. The patient must exert the diaphragm muscles in a full, oh my gosh, my cat, sorry. And a full stomach may interfere with this action. Number two, stop smoking at least 8 hours before the test. Number three, do not take bronchodilators for 4 hours before the test. Number four, do not engage in strenuous activity for 4 hours before the test. And number five, wear loose, non-restrictive clothing that to keep the chest area as free as possible, which makes it easier to perform the breathing maneuver.
Very good. Okay, so you guys are going to highlight 1, 2, 3, 4, and 5. All right, any questions on anything so far? Okay. All right, Jasmine, please read calibrations of the spirometer.
To ensure accurate and valid test results, the spirometer should be calibrated each day that the machine is used. Calibration is performed by injecting a known quantity of air into the spirometer. A large 3-liter spirometer syringe is used to inject 3 liters of air into the machine. The output should read 3L, and the reading should not vary by more than 3%. If the machine is not properly calibrated, the medical assistant should consult the operating manual and adjust the machine as required.
Very good, thank you. Okay, so you're just going to highlight the first sentence. Lily, please read post bronchodilator spirometer. I'm sorry, spirometry.
If the results of the spirometry test indicate a possible obstruction, the provider usually orders a post bronchodilator spirometry test. This test is performed by having a patient inhale a bronchodilator and running a spirometry test approximately 10 to 15 minutes later. The purpose of this test is to inform the provider as to how treatment would work in patients whose airways are obstructed. If the FVC or FEV1 parameter increases by at least 15%, the result is reported as positive for bronchodilator responsiveness. This means that the obstruction may be reversible or partially reversible through the use of medication.
Very good. All right. So now we're at case study number 3. Walter Conrad, 62 years old, comes to the office because he has been getting short of breath when he goes up and down stairs. He has worked in coal mines his whole life and has just retired. The physician orders a pulmonary function test. Walter tries to breathe like he is supposed to during the test, but he cannot do it, and he is getting dizzy from trying so hard. He also is having problems with the nose clips. He says they pinch his nose and he feels like he is being smothered. After 4 attempts, he puts down the spirometer in frustration and wants to know if he can come back some other time. He says that he is thinking his symptoms are not bad after all, and maybe he will just wait and see what happens and will come back if they get worse. Okay. What do we do?
Maybe we can have, or the physician can order a CT scan since he can't, get the breath to be able to actually do the test.
Okay. Anything else?
I think that we should document that he's worked in the coal mines his whole life, because doesn't that have some reactions with some things?
That's right. So what is one of the questions that we ask our patients on our health history forms?
Their occupation.
That's right. That's right. And this is one of those times that what the patient did for a living could be affecting his health. That's why we ask that. All right, very good. What else? Do we keep pushing Mr. Conrad to do the test?
No. I mean, I wouldn't think so, because you don't want to make him uncomfortable.
No, you're right. In a way, we don't want to make him uncomfortable,
But you can advise him that it's very important.
right. Yeah. So we don't want to force the patient, but this little bitty test really could give the doctor a lot of information to where more further testing may not have to be ordered, right?
I guess. Oh, keep going. I'm sorry.
No, go ahead. Go ahead.
I guess. What I'm saying is, like, if he is uncomfortable though, and he doesn't want to do the test, like, if he wants to do something else that might be easier and less, like, hard on his lungs or his breathing, then that's an option that you can offer him.
It is. Now, we wouldn't offer him, but yes.
Yeah, well, tell the physician. Yeah.
Right. You could let the doctor know, but we really want to try to get this patient to do this test. So it is very common when you are doing this test that you get dizzy. The fact that he's short of breath probably means that he's already kind of agitated, right? Imagine yourself to where, like, you can't breathe, like you constantly feel like you're not getting enough air. Over time, for some patients, it does make you a little agitated. And for those particular patients, they really just need to be like, take a deep breath, walk them through the procedure, right? Is it normal to get dizzy when doing this test? Yes or no?
I think it would be.
That's right. Yes.
Because I feel like whenever I blow up a balloon or a floaty, I start feeling dizzy and I can't, you know what I mean?
Yeah, 2 breaths into blowing a balloon, I feel like I'm gonna pass out.
Yeah.
Yeah, so it's very normal. So start understanding, start advising him that Mr. Conrad, it is really normal for you to feel dizzy. I know the nose clips seem to be uncomfortable, but they are designed to fit snugly so we can get a good, accurate reading. Just talk to them, right? Just sometimes your patients just need to have that conversation. All right, very good. So is there anything else that we could do for our patient?
Make him feel comfortable,
Yes.
like you said, pretty much.
Yeah. Yep. Yeah. And just ask him, can we, after you talk to him and he kind of calms down, just ask him, can we give it one more try, before, we try to see what else we can do. More times out of ever, they're going to say, yeah, let's go ahead and give it another try. They're upset. They're uncomfortable. Okay, so what do we not want to do?
We don't want to force him to do something he doesn't want to do. If he absolutely does not want to do it,
Yeah. Yep, then it's done. We are not going to force our patient because that's going to break that cycle. So yeah, at that moment, then you just say, okay, Mr. Conrad, let me go talk to the doctor and let's see what he or she advises. All right, very good. All right, any questions over anything so far? No? All right. All right, let's go to page 489. Peak flow measurements. Nancy, please read the first paragraph under asthma.
Asthma is a chronic lung disease that affects the small airways of the lungs. The trachea divides into the right and left primary bronchi. After the primary bronchi enters the lungs, they branch into smaller. Am I saying that right or wrong?
Bronchi.
Bronchi, known as the secondary and tertiary bronchi, and then into even smaller passages known as the bronchioles. The bronchioles continue to branch and finally lead into microscopic alveolar ducts, which terminate in clusters of tiny air sacs known as alveoli.
Yep.
Asthma affects the smaller bronchi, ondary, and periphery bronchi, and the bronchioles of the lungs.
Very good. Okay, so I want you to highlight where asthma is a chronic lung disease. And then I want you to also highlight the last sentence. All right, very good. Natalie, can you please read the next paragraph?
Asthma can occur at any age, but it is more common in children and young adults. Asthma affects boys more frequently before puberty and girls more frequently after puberty. In the United States, there are approximately 20 million individuals with asthma. Of these, 6 million are children. Each year, more than 4,000 deaths result from asthma.
Very good. Okay, so you're going to highlight the first sentence. Sabrina, please read the next paragraph, please.
Asthma is characterized by chronic inflammation of the small airways of the lungs and recurrent attacks of coughing, chest tightness, shortness of breath, and wheezing. Wheezing is continuous, high-pitched, whistling musical sound heard particularly during exhalation and sometimes during inhalation. In most patients, an asthma attack is followed by a symptom-free period. Asthma can be controlled by recognizing the warning signs and symptoms of an attack and treating them when they first occur. Failure to treat asthma can lead to serious complications such as permanent lung damage.
Very good. Okay, so you're going to highlight the very first sentence. All right, Talia, please read the next paragraph above asthma attack.
The exact cause of asthma is not known. It is, though, thought to be caused by a combination of factors including genetics, certain childhood respiratory infections, contacts with allergens, or exposure to certain viral infections in infancy or early childhood.
Very good. Thank you. Okay. Alicia, please read the first paragraph under asthma attack.
Asthma attacks are highly individualized. Depending on the patient, asthma attacks vary in frequency and severity and may come on suddenly or gradually. An asthma attack may last for only 10 to 15 minutes, or it may last for hours or even days.
Very good. Jasmine, please read the next paragraph. Lily, go ahead and read the next paragraph, please.
In a normal individual, the airway to the lungs are fully open, allowing air to easily into and out the lungs. In a patient with asthma, the airway are always inflamed and hypersensitive to certain stimuli that do not affect the airways of the individual. The stimuli are known as asthma triggers because they can trigger an asthma attack.
Very good. Thank you. Nancy, will you please go ahead and read the next paragraph?
Asthma triggers vary from one patient to another and may also vary from one season to the next. Examples of common allergens that may trigger an asthma attack include house dust, pollens, molds, animal danders, and cockroaches. Asthma attacks can also be triggered by environmental irritants, activities, or events including air pollutants, tobacco smoke, chemical fumes. Example, perfume, paint, gasoline, vigorous physical exercise, upper respiratory viral infections, exposure to cold, and emotional stress. It is sometimes difficult to determine what specific triggers cause a patient's asthma attack.
Good. Okay, so have you guys ever gone into an office or not even necessarily a doctor's office and you've seen a sign where it says, please do not wear perfumes or body sprays or perfume deodorants, lotions. Have you guys ever seen those signs?
I feel like I have.
Yeah. So the reason they put that out there is because they already know that they may have a higher volume of asthma patients. And because of the fact that it is known that certain loud smells for some patients are an easy trigger. So that's why it's kind of explaining, what some of the triggers are. So be on the lookout for that when you're when you're out in the field. All right, very good. Thank you, Nancy. Natalie, please read the next paragraph.
Where it says wait, I'm lost.
Where it says when the inflamed airways of a patient.
Oh, yeah, yeah. When the inflamed airways of a patient with asthma are stimulated by a trigger, a series of reactions occur that affect the bronchial tubes. The bronchial tubes begin to constrict and swell, causing the patient to experience asthma symptoms. Sometimes the symptoms are mild and go away, either on their own or with minimal treatment with medication. At other times, the symptoms become worse, leading to a full-blown asthma attack. During a severe asthma attack, the bronchial tubes continue to constrict and swell and become clogged with mucus. Figure 12.21. This results in less air moving into and out of the lungs, which leads to a decrease in the amount of oxygen available to the body. The narrowed bronchial tubes and decreased oxygen supply cause the patient to experience coughing, chest tightness, shortness of breath, and wheezing. It is important to treat symptoms when they first begin to occur to prevent them from getting worse and causing a severe asthma attack, which may require emergency treatment.
Good. Okay, so you guys are going to actually highlight all of the third paragraph. And then on that last paragraph, I just want you to highlight where it says, during a severe asthma attack, the bronchial tubes continue to constrict and swell and become clogged with mucus. All right, Sabrina, please read the first paragraph under diagnosis and treatment.
The provider diagnoses asthma through a careful and detailed medical history. Of particular importance to the diagnosis of asthma are the patient's symptoms, family history of asthma, home and work environment, and living habits. The provider also performs a thorough physical examination to detect symptoms resulting from asthma, such as wheezing. When the medical history and physical examination have been completed, the provider usually orders laboratory and diagnostic tests, which may include pulmonary function tests such as spirometry, allergy testing, and arterial blood gas studies.
Very good, thank you. Talia, please read the next paragraph.
Although asthma is a chronic disease with no cure, most patients with asthma are able to lead a normal life through proper management and treatment. The general treatment of asthma includes identifying and avoiding asthma triggers, if possible, and preventing all irritation. These symptoms through the what?
Alleviating.
Alleviating these symptoms through drug therapy. Two general categories of medication are prescribed for asthma: long-term control medication and quick relief medication.
Very good, thank you. All right, Alicia, please go ahead and read long-term and quick relief, the next two paragraphs.
Medication helps relieve bronchial inflammation and prevent symptoms from occurring. Controlled medication helps the patient have fewer and milder asthma attacks and is typically taken every day. Corticosteroids are an example of a controlled medication. Brand names include Flovent, Pulmicort, Asmanex, Qvar? How do you say that? Qvar? And Aerobid. Other examples of long-term control medication include Singulair, Accolade, Ceravent, Zyflo, and Advair. Medication, also called rescue medication, opens the airways quickly by dilating the bronchial tubes. It is taken when the patient is experiencing symptoms to prevent or control an asthma attack. Fast-acting bronchodilators are an example of quick relief medication. Brand names include Proventil, Ventolin, and Xopenex.
Very good. Okay, so for long term, what would be why? So explain to me why we would give patients a long term medication.
So they want to have to keep coming back and forth all the time.
Right, right. With long term medication, what does that do for the lungs?
To help them work better than usual.
Yes, so it does. So it helps relieve the inflammation and which ultimately will prevent the symptoms. Okay, so then a quick relief medication, also known as a rescue, that's when you're going to use to treat. So most asthmatic patients or patients with severe allergies that can become asthmatic, you will notice that they have both. They have a long term and they have a short term or a rescue. So the long
Sister does. Sorry, I didn't mean to cut you off.
no, you're good. So that's right, and that's because most people do. So you will notice that. So they have a long-term medicine that helps keep the inflammation down and kind of help repair the lungs. And then for the times when they have a flare-up or an attack, they're going to get out their rescue medication or their rescue inhaler. Now, Singulair. Has anybody heard of that medicine before?
That's the one my sister uses.
Okay. Would you consider so Singulair is also a medication that is used to treat allergies. So what I would advise is that you make a note. If you see that your patient is on Singulair, go ahead and ask them what they are taking it for. because it could be that they're taking it for allergies and not asthma, or vice versa. And we really need to make sure that we have that documented. All right, very, very good. Jasmine, please read the last paragraph above peak flow meter.
Many asthma medications are delivered through an inhaler, which allows the medication to go directly to the lungs. Quick release medication can be used in a breathing machine known as nebulizer to treat an asthma attack at home. Other asthma medications are administered orally. However, they take longer to work because they first have to travel through the digestive and circulatory system before reaching the lungs.
Very good. Okay, so if so, most patients, not all, but most asthmatic patients or patients with lung sensitivity, they'll have a nebulizer. Nebulizers are generally very easy to learn how to work, and they really do work really good. I keep one for my girls just because they had, when they were infants, we had a lot of problems. So nebulizers work amazing. Okay, any questions on that? All right. Peak flow meter. Lily, please read the first paragraph.
Peak flow meter is a portable handheld manual or digital device used to measure a breathing maneuver performed by the patient. A manual peak flow meter consists of a plastic tube with a sliding indicator that manually moves along the scale of numbers when the patient performs the breathing maneuver. A digital peak flow meter automatically measures the breathing maneuver and displays the measurement digitally on the screen. Because the manual meter is currently used most often, the remainder of this unit will focus on the manual peak.
All right, very good. So just like with their safety devices, yes, it's good to know how, but let's make sure that you guys also know how to read a manual one, be able to do a manual one. All right. Sabrina, do you have a question, dear?
No, I just saw her comment.
Oh, okay. All right. So Nancy, please read the next paragraph.
That's where it says a peak flow meter is used.
Yes, ma'am.
A peak flow meter is used to measure how quickly air flows out of the lungs when the patient exhales forcefully. Peak flow meters are frequently used by patients with asthma and are recommended for patients with moderate to severe asthma. The measurements obtained from a peak flow meter are not as accurate as those obtained by spirometry. However, a peak flow meter can be used easily by a patient at home.
Very good. Okay, highlight that first sentence. Natalie, go ahead and read that next paragraph, please. Okay, that's all right, Natalie. Thank you. Sabrina, can you go ahead and read that next paragraph?
Peak flow measurements provide patients with important information such as when to take their medication and how severe an asthma attack is. Several different brands of peak flow meters are available, and peak flow measurements may vary among brands. Because of this, a patient who purchases more than one meter should always use the same brand to obtain consistency among measurements.
Very good. All right, Talia, go ahead and read the next paragraph.
Peak flow meters can be purchased over the counter and are available in two ranges: a low range and a full Range. The low range meter has a range from 0 to 300 and is used by young children and some older patients. The full range meter has a range from 0 to 800 and is used by older children, teenagers, and adults. Figure 12.25. An adult has much larger bronchial tubes than a child and needs the wider range.
Very good. Okay, highlight where it says the low range meter has a range from 0 to 300 and is used by young children and some older patients. All right, peak flow rate. Alicia, go ahead and read the first paragraph for peak flow rate.
The peak flow rate, PFR, is the maximum volume of air measured in liters per minute, L/min, that can be exhaled when the patient blows into a peak flow meter as forcibly and as rapidly as possible. The PFR is obtained by having the patient perform a breathing maneuver.
Very good. All right, Jasmine, please read the next paragraph.
The patient is instructed to take a deep breath until the lungs are completely full. After this, the patient is told to blow all the air out of the lungs and into the mouthpiece of the peak flow meter as hard and as fast as possible. When you want me to keep going? Oh, that keeps going. Okay, sorry. The patient blows into the peak flow meter. His or her breath causes a sliding indicator to move up the scale of the meter. The indicator stops and remains at the patient's PFR. To obtain the most accurate PFR, the patient should perform 3 acceptable breathing maneuvers and then record the highest of the 3 measurements. The 3 measurements should be about the same to show that an acceptable breathing maneuver was performed each time. This is especially important to know when parents are evaluating a child's peak flow measurement.
Very good, thank you. All right, Lily, go ahead and finish up that last paragraph above schedule of use.
The medical assistant is often responsible for instructing a newly diagnosed asthma patient in the procedure for using a peak flow meter. In addition, the medical assistant may be responsible for obtaining the PFR of a patient with asthma at the medical office. The procedure for measuring PFR is outlined in Procedure 12.4.
Good. Schedule of use. A peak flow meter should be used on a regular schedule by patients with moderate to severe asthma to determine how well their asthma is being controlled. The provider determines each patient's schedule based on the severity and frequency of asthma symptoms. Most providers recommend that the patient use a peak flow meter at least once a day, preferably in the morning before taking asthma medications. A peak flow measurement should also be obtained when the patient is having symptoms. If the patient has more severe form of asthma, the provider may want the patient to use a peak flow meter twice a day, in the morning and in the evening. Peak flow measurements are usually recorded on a peak flow chart, which allows the patient and the provider to track changes in the patient's lung functions over a period of time. A peak flow chart consists of graph paper with a range of peak flow numbers, usually from 50 to 800 liters per minute, listed in the vertical column on the left side of a graph paper. The patient indicates the date and time at the top of the chart. After obtaining a peak flow measurement, the patient places a dot across the peak flow number in the appropriate column. A sample peak flow chart usually accompanies a peak flow meter and can be photocopied for ongoing use. All right, purpose of peak flow measurements. Peak flow measurements allow providers and patients to monitor changes in the patient's airflow to determine how well the patient's asthma is being controlled. A high number usually means that air is moving easily out of the patient's lungs. A low number usually means that the airways are narrowed and air cannot move easily through them, resulting in a decrease in oxygen available to the body. Peak flow measurements are used to do the following. Number 1, monitor how well the asthma is being controlled. Highlight that sentence. Number 2, highlight change or adjust medication. Number 3, highlight recognize early changes before symptoms occur. Number 4, highlight to determine the severity of an asthma episode. And number 5, highlight assist in identifying asthma triggers. Okay, figure 12.26 is an example of a peak flow chart. So this is how a patient would document at home, right? So we have our date is at the top and the time, and then where it measured. So on this particular day, it was look like it maybe a 501. The next day, it dropped to 500, and so on and so forth. All right, care and maintenance. It is important to instruct the patient in the proper care of the manual peak flow meter because dirt collecting on the meter can result in inaccurate measurements. The meter is cleaned by washing it weekly with warm soapy water and then rinsing it thoroughly with warm water. Excess water should be removed by gently shaking the meter. The meter should then be allowed to air dry completely before it is used. Many peak flow meters can be cleaned by placing them in the dishwasher on the top shelf. Check the manufacturer's instructions for this information. The peak flow meter should be inspected periodically for damage such as cracks, which could cause air to leak out of the meter, leading to inaccurate readings. Highlight that sentence. With proper care, a peak flow meter should last 2 to 3 years. Okay, so let's turn to page 494. Highlight the first sentence on the number 1 principle. Highlights A, B, and C on number 4 procedural step. On page 495, highlight the principle on number 5. And highlight the procedural step number 13. And then we're going to go on over to page 496. Home oxygen therapy. Oxygen is a colorless, odorless, and tasteless gas that is vital to the human body. Oxygen is transported by the blood to various tissues of the body. When it reaches the tissues, oxygen is taken into the cells where it combines with glucose to produce energy. Highlight that sentence. Energy is necessary to the body for carrying out all metabolic processes that sustain life, such as breathing and beating of the heart. When the lungs cannot deliver enough oxygen to the body, there is a reduction in the amount of oxygen in the blood, resulting in hypoxemia. Hypoxemia is defined as decrease in the oxygen saturation of the blood. Hypoxemia in turn leads to hypoxia, which is a reduction in the oxygen supply to the tissues of the body. Failure to maintain an adequate blood oxygen level can result in progressive deterioration of the patient, beginning with the death of cells, and if prolonged, continuing to organ failure and eventually body system failure and death. Highlight where it says hypoxemia all the way down to the end of that paragraph. There are certain conditions such as severe chronic obstructive pulmonary disease, COPD, that reduce the amount of oxygen in the body, resulting in hypoxemia. In these cases, the provider may write a prescription for home oxygen therapy. Oxygen therapy is the administration of supplemental oxygen at concentration greater than room air to treat or prevent hypoxemia. Oh, goodness. Oxygen therapy increases the oxygen supply to the lungs, which in turn raises blood oxygen to normal levels and increases the availability of the oxygen to the tissues. Oxygen therapy helps to alleviate the effects of low oxygen levels such as shortness of breath and fatigue and help the patient have a better quality of life and live longer. Home oxygen therapy is most commonly prescribed for patients with severe COPD caused by smoking. Other common causes of hypoxemia that may require home oxygen therapy include asthma, occupational lung disease, lung cancer, cystic fibrosis, and congestive heart failure. Highlight that sentence. Home prescription. The provider determines a patient's need for oxygen therapy through clinical observation of the patient and by measuring the oxygen level of the patient's blood. Clinical signs of hypoxemia include cyanosis, dyspnea, tachypnea, tachycardia, and anxiety. Highlight that sentence. The oxygen level of the blood is typically measured by arterial blood gas, ABG, analysis and through pulse oximetry. A normal individual should have an ABG analysis of 75 to 100 MEHD and a pulse oximetry reading above 94%. An ABG analysis less than or equal to 55 mg/HD and a pulse oximetry reading of 88% or less warrants the use of supplemental oxygen. The goal of oxygen therapy is to maintain a blood oxygen level of 65 as measured through ABG analysis and 90 to 93% as measured through pulse oximetry. Once the need for supplemental oxygen has been determined, the provider must write a prescription for oxygen therapy that is filled by a home medical supply company. The prescription must include the amount and duration of supplemental oxygen needed by the patient. Highlight that sentence. Which are based on the severity of the patient's condition. In addition, the prescription includes the recommended oxygen delivery system and the administration device, which are described in the next section. Highlight that sentence. The amount of supplemental oxygen prescribed for a patient is known as a flow rate, which is measured in liters per minute. For example, if a patient has been prescribed 2 liters per minute, each minute 2 liters of oxygen will flow from the patient's oxygen delivery system into tubing and then into the patient's upper airway. As previously described, the flow rate prescribed by the provider is targeted at raising the patient's ABG analysis to 65 and the pulse oximetry measurement to 90 to 93%. Most people with COPD start out with a flow rate of 1 to 2 liters per minute. As their COPD worsens over time, the flow rate may increase to 3 to 6 liters per minute. The duration of the oxygen therapy refers to the number of hours per day oxygen therapy is administered and, depending on the patient's lung function, can vary from a few hours a day up to 15 or more hours per day. Some patients need oxygen only when sleeping or exercising, whereas other patients with more severe hypoxemia may require continuous oxygen therapy. Continuous oxygen therapy refers to the use of oxygen for more than 15 hours a day. Once oxygen therapy is initiated, periodic assessment of the patient's blood oxygen level is required. This assessment is necessary to make sure that the patient still requires oxygen therapy and that the amount and duration of oxygen are adequate to meet the patient's oxygen needs. All right, Nancy, will you please read oxygen delivery systems?
There are 3 common for providing supplemental oxygen to a patient: compressed oxygen gas, liquid oxygen, and oxygen concentrate. The type of delivery system prescribed by the provider is based on the patient's condition, the patient's personal preference, the ease of the equipment used, and cost. Each of these delivery systems can be used alone or in combination with another system to meet the oxygen needs of the patient. These systems are described in greater detail in the next section.
Very good. All right, Natalie, will you please read the first paragraph for compressed oxygen gas?
Where it says there are 3 common delivery.
No, the next paragraph.
Compressed oxygen gas is oxygen gas compressed under high pressure and then stored in a container referred to as a cylinder or tank. Compressed oxygen cylinders vary in size from large stationary cylinders to small portable cylinders that can be carried around. Figure 12.27a. The patient uses a large cylinder of compressed oxygen at home. When the patient goes outside of the home, he or she uses a small cylinder that has been placed in a carrying device such as a shoulder bag.
Very good. Thank you. Sabrina, can you please read the next paragraph?
The cylinder is equipped with a regulator and a flow meter that control the flow rate of the oxygen. The flow of oxygen out of the cylinder is constant. To conserve oxygen and avoid waste, an oxygen conserving device may be attached to the system. An oxygen conserving device releases the oxygen gas only when the patient inhales and cuts off the release of oxygen when the patient exhales. Advantages and disadvantages of compressed oxygen gas include the following.
Very good. Talia, can you go ahead and read the advantage and the disadvantages, please?
Advantage: compressed oxygen gas is less expensive than liquid oxygen. Disadvantages: the oxygen cylinder must be refilled frequently. A compressed oxygen gas cylinder cannot be taken on a commercial airline.
Very good. Thank you. All right, Alicia, can you please read the first paragraph for liquid oxygen?
When oxygen gas is subjected to an extremely cold temperature, it changes from a gas to a very cold liquid. The liquid oxygen is stored in an insulated tank with a lining similar to a thermos. Oxygen in a liquid form takes up much less space than compressed oxygen gas. For example, 1 liter of liquid oxygen is equal to 860 liters of compressed oxygen gas. Because of this, a container of liquid oxygen lasts 4 times longer than compressed oxygen gas of the same weight.
Very good. Jasmine, can you please read the next paragraph? Lily, can you please read the next paragraph?
A liquid oxygen system consists of a large stationary tank that serves as the primary uh, reservoir of oxygen. A small portable tank weighing between 5 and 13 pounds is filled from the large primary tank for use outside the home. The portable tank can be hung over the shoulder or pulled on a roller. When liquid oxygen is released from its tank, it changes into a gas and the patient breathes it in, similar to breathing in compressed oxygen gas. Advantages and disadvantages of liquid oxygen include the following.
All right, Nancy, will you please read advantage and disadvantages?
We're on the one that's right under liquid oxygen, correct?
Yes, the advantage and disadvantages.
Okay. Sorry, I keep asking because it keeps cutting off from me on my end.
That's okay. It's fine.
Because it takes up less space and it is easier to transport than compressed oxygen gas. Liquid oxygen is often preferred by individuals who want to maintain an active life. Disadvantages. Liquid oxygen is more expensive than compressed oxygen gas. The contents of a liquid oxygen tank evaporates, making it necessary to have the tank refilled often. A liquid oxygen portable tank cannot be taken on a commercial airliner.
Very good. Thank you. All right, Natalie, can you please read the first and second paragraph for oxygen concentrator?
An oxygen concentrator is an electrically powered device that weighs about 35 pounds and is about the size of a large suitcase. Figure 12.29a. It works by separating oxygen out of the air, concentrating it, and then storing it for use by the patient. The oxygen concentrator is equipped with a built-in flow meter, which allows the prescribed flow rate to be set. Small portable battery-powered oxygen concentrator systems weighing about 10 pounds have been developed. Figure 12.29b. They can provide a patient with oxygen for about 8 hours when used at a flow rate of 2 liters per minute. For many patients, portable oxygen concentrators have replaced liquid oxygen or compressed gas cylinders. For mobility, advantages and disadvantages of oxygen concentrations include the following.
All right, very good. On the first paragraph, I want you ladies to highlight where it says it works by separating oxygen out of the air, concentrating it, and then storing it for use by the patient. All right, Sabrina, can you please read advantages and disadvantage?
Oxygen concentrators do not need to be resupplied with oxygen from a home medical supply company. Oxygen concentrators are less expensive and safer than oxygen cylinders. Portable oxygen concentrators that are battery powered offer the patient even greater freedom and mobility than other oxygen delivery systems. Some portable oxygen concentrators have been approved by the Federal Aviation Administration (FAA) for use of commercial airlines. Disadvantage: because oxygen concentrators use electricity, if the power goes out, the patient must have a compressed oxygen gas cylinder for use as a backup.
Very good, thank you. All right. Oxygen administration devices. A device must be used to administer the oxygen to the upper airway of the patient from the delivery system. The device usually depends on the expected duration of therapy and the personal preference and needs for the patient. The most commonly used devices to administer home oxygen therapy are the nasal cannula and a face mask, which are described in greater detail here. Okay, Talia, please read the first paragraph for nasal cannula.
A nasal cannula is the most frequently used device for administering home oxygen therapy. A nasal cannula consists of soft plastic tubing with a two-pronged device that is inserted into the patient's nose, figure 12.30a. The tubing of the prolonged loops over the patient's ears and is secured under the chin, figure 12.30b. The tubing connects to the delivery system, i.e. compressed oxygen cylinder, liquid oxygen, or oxygen concentrator. The primary advantage of the nasal cannula is that it does not interfere with the patient's ability to talk, eat, or drink.
Very good, thank you. Okay, so you're going to highlight the first two sentences and the last sentence. So if someone says nasal, what does that mean? What body part are we talking about?
The nose.
That's right, the nose. All right, very good. Alicia, please read the next paragraph.
The concentration of oxygen, right?
Yes, ma'am.
Okay. The concentration of oxygen inhaled by the patient depends on the flow rate described by the provider. A nasal cannula can deliver oxygen at a flow rate between 0.25 and 6 L. I forgot what that meant. L. What does that mean? Hold on.
Flow rate between 0.25 and 6 liters per minute.
Liters per minute. There you go. Okay. Liters per minute. If the flow rate is greater than 4 liters per minute, it can dry out the patient's nasal passages. To prevent this from occurring, a humidifier should be used to provide moisture for a flow rate of above 4 liters per minute. And you, in the first paragraph, you said highlight the first two and then the last one.
Yes. First
Okay,
paragraph.
just making sure.
First two sentences and the last sentence.
Okay.
All right. Lily, will you please read the next paragraph?
The cannula should be washed once or twice a week using liquid soap and water. Rinse thoroughly and allowed to air dry. The cannula should be replaced with a new cannula every 2 to 4 weeks.
Very good. All right, Nancy, can you please read the first paragraph for face mask?
A face mask consists of plastic and fits over the patient's nose and mouth. A face mask strap is then tightened around the patient's head to ensure a secure fit. Figure 1231. Oxygen tubing is used to connect the face mask to the oxygen delivery system. A face mask is not used as frequently as a nasal cannula to administer oxygen because it is bulky and must be removed for eating or drinking and to communicate effectively.
Very good. All right, Natalie, please read the next paragraph.
A face mask is often used for patients who need a high flow of oxygen. It can deliver oxygen to the patient at a flow rate between 5 and 15 liters per minute. Wearing a nasal cannula for an extended period of time can irritate the nose. Because of this, the patient might prefer to wear a nasal cannula during the day and a face mask at night to reduce the irritation that may occur from a nasal cannula. The patient who has nasal congestion from a cold will also prefer a face mask.
Very good. Thank you. Okay, you're just going to highlight the first sentence. Sabrina, go ahead and read that last paragraph.
The face mask should be washed once or twice a week using liquid soap and water, then rinsed thoroughly and dried. The face mask should be replaced with a new one every 2 to 4 weeks or sooner if it becomes cracked or discolored.
Very good. All right, Talia, please read oxygen guidelines.
The home medical supply company that provides the patient with the oxygen equipment that gives the patient specific instructions on safe use, care, and maintenance of the equipment. List below are general usage and safety guidelines that the patient should follow.
Very good. All right, Alicia, if you will read the usage 1, 2, 3, and 4.
Number 1. Contact the provider if any of the symptoms of a low blood oxygen level occur, which include frequent headaches, anxiety, cyanosis of the lips or fingernails, drowsiness, confusion, restlessness, and slow, shallow, difficult, or irregular breathing. Number 2, keep the oxygen delivery system clean and free from dust. Number 3, do not change the oxygen flow rate unless directed to do so by the provider. Number 4, do not use alcohol or take any other sedating drugs as these substances will slow the breathing rate.
Very good. Lily, please read 5, 6, and 7.
Order more oxygen from a home medical company in a timely manner. To prevent the cheeks or skin behind the ear from becoming irritated, tubing, tuck some gauze under the tubing. If you have present redness under your nose, contact the provider. Oxygen therapy dries out the inside of the patient's nose and mouth. Use water-based lubricants on the lips or nostrils to relieve the drying effect. Do not use oil-based products such as petroleum jelly.
Very good. All right, Nancy, will you please read 8 and 9?
Do not use more than 40 to 50 feet of tubing with the oxygen delivery system to avoid bending or twisting of the tubing to ensure unobstructed oxygen flow. Number 9, people are not allowed to bring compressed oxygen cylinders or liquid oxygen tanks on board an airplane. Many airlines will provide oxygen if notified 48 to 72 hours in advance.
Very good. All right, you're going to highlight number 8. Natalie, please read the first paragraph for safety.
Oxygen is a safe gas as long as it is used properly. Oxygen itself is not flammable, nor will it explode. However, it greatly increases the combustion rate of a fire. If something catches fire, oxygen will make the flame hotter and cause it to burn faster and more vigorously. The result is that a fire involving oxygen can appear explosive like.
Very good. All right, Sabrina, will you please read 1, 2, and 3?
Store oxygen in a clean, dry, well-ventilated room. If kept in a closed area such as a closet, the smaller amount of oxygen gas that is continually vented from these units can accumulate in a confined space and become a fire hazard. Compressed oxygen cylinders and liquid oxygen tanks must remain upright at all times. Secure oxygen cylinders and tanks to a fixed object or place in a stand. Never smoke while using oxygen. Do not allow smoking in the room where the oxygen is kept. Post no smoking oxygen in use signs where oxygen is kept.
Okay. So I want you ladies to highlight the first sentence on both 1, 2, and 3. And then I'm going to share a funny story. Okay, so number 3 says never smoke while using oxygen. Okay, so my grandfather, he's passed away several years. He had emphysema. And what is emphysema? Anybody? Anybody?
Before, but I don't know exactly what it is.
Okay. In your own words, what is it? You can use Google if you need to.
Didn't we talk about that? I think on chapter of the shots. I think so. Chapter
The
11.
breath.
What is it?
Shortness of breath. A lung condition that causes shortness of breath.
Yes. Okay. So very good. So so my grandfather, he smoked. And I mean, he was a smoker, like packs and packs a day. Like every time they would go to the gas station, they would buy the cartons, right? So at one point during my grandfather's emphysema, before he went right into lung cancer, they put him on oxygen. Now, at the time, my grandparents lived in a little town called Buffalo, Texas. And we would go there every other weekend and just kind of spend the weekend. Well, every time we would go, I'm like, Pepaw, you cannot smoke around your oxygen tank. And he would. That sucker would be right by him and he would have a cigarette in his hand. He was older and ornery and stubborn. And he said, well, I'm going to die one way or another. At least I'll go out with a bang this way. I was like, oh my gosh, that's awful. He was such a funny guy. But funny story, because a lot of our older patients, especially if you put them on if your doctor puts them on oxygen and they're a smoker, most of the time you do need to ask them because they will smoke around their oxygen tank and it's not a good thing. They need to not do that. All right, let's see here. Talia, please read 4, 5, and 6.
Keep the oxygen supply at least 6 to 8 feet away from open flames such as gas stoves, lighted fireplaces, and candles. Keep the oxygen supply at least 6 to 8 feet away from intense heat such as radiators, furnace, and space heaters. Keep the oxygen supply away from flammable products such as cleaning fluid, paint thinners, and aerosol spray.
Very good. All right, Alicia, finish up 7, 8, and 9.
Number 7, do not lubricate oxygen equipment with oil or grease as the substances are flammable. 8, be sure to have functioning smoke detectors in the home. Number 9, buy a fire extinguisher and be familiar with how to use it. Check out the Evolve site to access interactive activities, procedure videos, and other helpful study resources.
All right, so ladies, that is it for chapter 12, okay? So make sure that you go back and you read this chapter, right? Really study it. Look over the terminology view, look over the procedures, look over the figures. Really good on this chapter. It's going to give you some really good, useful information. You need to make sure you do chapter 11, test bank, and chapter 12, evolve assignments. For your binder, again, the only worksheet I want is this sheet filled out, okay? That's all I want. Everything else is for you to study, learn, read. If you find that you're still having trouble understanding the CCMA EKG study guide, let me know. I'm happy to do one-on-one tutoring. But again, that's just there because it's a big thing on your certification that you understand. You're able to see, okay, what is the AD, where's the QRS, things like that. Now, on chapter 12, again, the one thing you do need to study is going to be on page 463 in figure 12.11. Okay, if you have not already sent me your study guide, chapter 11 results, please make sure you do so. This morning, I sent names of some students that have not received certain assignments and quizzes. Make sure you look over that. Does anybody have any questions, concerns, comments? No? Okay. Well, the worksheet in your binder, that's due by midnight tonight. All right, you ladies are free to go.